Hello, friends. I'm Dr. Bharat Jagiasi, and today we are going to talk about clinical implication of resistant patterns of MDRs in critical care. And in this session, particularly, we'll talk about the intrinsic resistance. So we all know commonly the reality of resistance is we have a patient in ICU who develops septic shock, and culture shows non-lactose fermenting gram-negative bacilli. And with the kind of report we get, we can eventually dictate the treatment and also let us know about the prognosis, how is this patient going to behave in next few days. And in this whole agenda, our journey through MDRO resistances, we'll talk about the resistant mechanism. And in this talk, mainly about the intrinsic resistances. We'll also learn a little bit about the culture report investigations and targeted therapies over a series of few talks. So we all know MDRO is no more related or attributed only to the microbiological labs and the academics. We almost 1.27 million annual deaths, which have been attributed to the antimicrobial resistance, and eventually more probably because of the many different organisms, Klebsiella, Acinetobacter, and 60 to 70% of those are resistant to the our main therapy. What we think of is the carbapenem, and what we look into the different mechanisms are the ESBL producers, carbapenemesis, and the MDR, Acinetobacter, and the Pseudomonas. So when we talk of the antimicrobial resistance, we have a category, something called as MDR, XDR, PDR. We all know MDR is multi-drug resistant, and we call it as a multi-drug resistant when there's non-susceptibility to at least one agent in three or more antimicrobial categories. We call it XDR, that is also known as extensively drug resistant, which is non-susceptibility to at least one agent in all but two or fewer antimicrobial categories. PDR is pan-drug resistant, non-susceptibility to all agents in all antimicrobial categories. So this is what we need to learn, and this is an exam question as well. What does it mean by MDR? What does it mean by XDR? And what does it mean by PDR? Escape, we all know this. This term was introduced by Dr. Rice in 2008. So basically, he talked of the most common pathogens, those are multi-drug resistant organisms, and two were from the gram-positive group, and the rest four were from the gram-negative group. So from the gram-positive group, we had the Enterococcus faecium and Staphylococcus aureus, and from gram-negative group, we have Klebsiella pneumonia, Acinetobacter baumannii, Pseudomonas aeruginosa, and Enterobacter species. And these days, we also have something called as SKP, that is, we have double E in the end to include E. coli in this pattern. And what we face commonly in our critical care is carbapenem resistant Enterobacteriaceae, very high prevalence in Indian hospitals, almost 42% in 2023, and they are associated with almost 50% of mortality. Then we have the MRSA, that is methicillin resistant Staph aureus, which is more common in the West as compared to what we face it, and then MDR Pseudomonas and MDR Acinetobacter baumannii. So the moment the plate is being laid, we get the initial clues. So initial laying of the plate tells us whether it's pink or pale, and that is the first clue to the resistance. So lactose fermenters are pink and non-lactose fermenters are pale. So lactose fermenters are mostly of the gut flora origin, and they are most commonly E. coli Klebsiella, and they are ESBL producers. Or the CRE is rising in their case. When it comes to the pale plate, those are the non-lactose fermenters. And the problem is, though, they have a high intrinsic resistance. This is what we are going to understand in this talk. And they rapidly acquire resistant mechanism. And the only resistant mechanism is not enzymatic in those cases. They have a different mechanisms also to acquire, and they are the very difficult to treat organisms. So as we spoke of the lactose fermenters, which is pink in color, it could be the E. coli, Clab pneumonia, Enterobacter species. And as spoken, they often expresses as ESBLs, KPCs, and NDMs. And non-lactose fermenters are usually pale colonies on the Meckenkie agar, and because they cannot utilize lactose, and they are Acinetobacter, Pseudomonas, Stenotophomonas, and they often express as MBLs, Oxida, carbapenemesis. So non-lactose fermenters, they have the intrinsic resistant mechanisms, and they also are very common in biofilm formation, and they adopt resistant mechanism very fast, and this is why they are more dangerous and mortality is very high, and we have very limited treatment options with them. So when I talk about the Pseudomonas, we'll cover all the treatment strategies in detail in the further talks, but here I just wanted to streamline it. When you talk of the Pseudomonas treatment strategies, so we have the MDR, and most commonly what works is Caптolozan, Tazobactam, and what we've been using these days is Tazobactam. And in XDR cases, we can use colistin-based combinations or the Capidarocol. And the PDR, then we have to look for the novel combination, dose optimization, and PK/PD approaches. When it comes to the Acinetobacter, a critical care challenge, it is 85% of them are carbapenem resistant, and they have very high mortality of 70%. And what treatment we can look into in those cases, colistin-based combination, we consider high dose of sulbactam. So sulbactam eventually as an isolate is not available. So we use most commonly a combination of ampicillin and sulbactam to target this, and we can use digicycline for non-pulmonary infection in these cases. So why other lactose or non-lactose fermenters are concerned are it's Stenotrophomonas maltophilia and Burkholderia cepacia complex. So Stenotrophomonas, we need to know this, they're intrinsically resistant to the carbapenems. And cotrimoxazole is the first line of the treatment along with the levofloxacin, and minocycline is also shown to be is known to show the promising results. When it comes to the Burkholderia species, it has multi-influx systems, so they work in different ways, and they are very commonly associated with biofilm resistance. And again, we can use a combination therapy in those cases as well. So first hour, or maybe in the first few hours, the moment we laid the plate, whether it's pale or pink, it can give us a clue whether it's a lactose fermenter or non-lactose fermenter, so that we can eventually guess what kind of bacteria and what kind of resistant patterns they are going to acquire and what should be our antibiotic strategy. So if it's a lactose fermenter, then I know it could be the E. coli, CLEP, as it's there in my ICU, and most probably they are ESBL producer or the carbapenems, and the empirical strategy in those cases could be the BL-BLI combos or the carbapenems. And non-lactose fermenters, we all are aware, they are most dangerous bugs, have the intrinsic mechanism, could be Pseudomonas, Acinetobacter, and again we have to use, as discussed, anti-Pseudomonal and anti-Acinetobacter strategies in those cases. So this was about like lactose and non-lactose fermenters. And now we will talk about understanding the genetic foundation, how the resistant mechanism works. So resistant mechanism could be the intrinsic resistant mechanism that is naturally present regardless of the exposure, or it could be the acquired resistant mechanism, which could be acquired through mutation, gene transfer, or the antibiotic pressure. That is the misuse of the antibiotics what we practice. But in this talk, we'll talk mainly about the intrinsic resistance, and the acquired resistance will be spoken in the next talk. So we have to understand resistance starts at the genetic level. So intrinsic resistance, as we spoke, is present regardless of the exposure. And many Pseudomonas are resistant to many beta-lactams. Enterococci are resistant to cephalosporin. And acquired resistance could be by the antibiotic pressure, and they have the different various mechanisms. So both are the different things. So if you look at this chart, resistance is natural and acquired. Natural could be innate or the mediated, and acquired could be to the horizontal gene transfer, which could be achieved either by the translation, conjugation, transposition, or the mutation in its own chromosomal DNA. So intrinsic resistance is something they are born with. They are hardwired right from the birth. So if you ask about Pseudomonas, they are naturally resistant to penicillin and first and second generation cephalosporins. Acinetobacter species, they are naturally resistant to ampicillin and the first and second generation cephalosporins. Enterococcus species, they are resistant to the cephalosporins and low level of aminoglycosides. And Klebsiella species are resistant to the ampicillin and so on. We'll look into. So these are the bacteria who are born with these resistant mechanisms. So supposedly in my ICU, there is a non-lactose fermenter. So I suspect there's a Pseudomonas or Acinetobacter which has grown. So I know my first and second generation cephalosporin or ampicillin and penicillin are now going to work in that group. Same goes with the lactose fermenter. Suppose the CLEB has grown as a lactose fermenter, then I know ampicillin is now going to work. So this kind of mechanism, identifying whether it's a lactose fermenter or non-lactose fermenter in the initial hours, even before you have the real bacterial growth, can help you decide the actual real empirical antibiotics. So examples of bacteria showing intrinsic resistance, what they are born with, they are wired with it. Basically, this is the list. You can take a picture of this and keep it as a reference list in your ICU, where we all know all gram-positive bacteria are Astronome resistant. Pseudomonas, laughing at sulfonamides, ampicillin, first generation, second generation cephalosporin. Stenotrophomonas walk over through carbapenems. You cannot be using carbapenem when it's Stenotrophomonas because they are intrinsically resistant to. And Acinetobacter again can easily fight out. I wouldn't say even fight out. You have already lost the game if you're using being ampicillin or the glycopeptides Acinetobacter. So it's very important to know the intrinsic mechanism to decide about the empirical therapy, because those bacteria are resistant to certain antibiotics right from their existence and their evolve. So this is a quick ICU sheet which tells you about the natural resistance. You take a picture of it. So Pseudomonas, of course, those will be resistant to ampicillin first and second generation. We have to use anti-pseudomonal beta lactams. Acinetobacter, as we spoke about, they are resistant to the sulfonamides and many beta lactams, and we have to consider sulbactam combinations in those cases. Same is true with the enterococcus resistant to the cephalosporin. We could be using either ampicillin or vancomycin. If it's CLAB, you cannot be using ampicillin as they are intrinsic resistant to it. So we talk of intrinsic resistance and we also understand the practical implications. So as I spoke to you, as we understand, maybe it's a non-lactose fermenter. So could be in my ICU Pseudomonas is more common. So we all know it's naturally resistant to ampicillin. So my antibiotic of choice in those cases would be maybe the pip/tazo and the ceftazidime. Same if suppose Acinetobacter is more common in my ICU and it's a non-lacto fermenter, I will consider using high dose of sulbactam, maybe the different agents, but I know these are resistant to the beta lactams and the aminoglycosides. So now comes to the acquired resistance. I'll just cover one slide in this, and eventually in my next particular coming talks, I'll talk about in detail about the acquired resistance also by the Ember classification. So they come with a varied mechanism, could be the enzymatic inactivation, could be the target modification, or the efflux pump, or the permeability changes. So this will understand later and how important are this and what antibiotics in the subsequent talks. So as of now, uh, if it's a enzymatic activation, they could have the ESBL and KPC. If it's a target modification, it could be the DNA gyrase mutation or the ribosomal methylation. If it's a permeability changes, it could be the porin channel alterations. So thank you for grateful for your time and attention. And eventually we start with series of identifying the resistant mechanism, and then maybe we'll come to the second part of the series of reading out the culture reports and the biomarkers. Thank you for listening. Thank you very much.